Hey, everybody, welcome back to the Overrun Podcast. Ed Bouter, Dan Schwester, and
Hey,
Scott
everybody.
Weingart is on the show
Yes.
this
Yeah,
month.
fun for
Dr.
everyone
Weingart,
here.
how are we doing?
So good. Great to be talking to you folks.
Really excited to have you. As a quick programming note, this show has started as a beneficiary of one of Scott Weingart's conferences. Danny and I went to a conference in 2018, had a couple drinks afterward and started the Overrun Podcast. So, Scott, thank you for that. We appreciate all the work you've done in EMS, and nothing else I'm going to say is something you haven't heard before. So let's go ahead and get into why the theme of this episode is upstairs care out there. And what we wanted to do is kind of blend the idea of what happens in the ER, what happens in your ER, and what we're doing out in the field, and kind of marry those two. So jump right into it. I want to talk about whole blood. It's a big topic in EMS. It's a big topic in critical care. We had Peter Antevy on a couple weeks ago to talk about spray dry plasma. So let's start low titer whole blood in EMS generally. Talk to us about your opinions of it, logistics, costs, all those kind of things. Let us know what you think about it.
Yeah, well, blood in general, it makes complete sense for a critically ill trauma patient to be doing it in the field. So I think hopefully that debate's won. I mean, we have emerging literature. We've had literature over the past few years that have shown the benefits. And, depending on your system, if it's going to be any reasonable amount of transport, then it just doesn't make sense to do nothing or to temporize with IV fluids. And we know all of the evils that come with that. So blood in the field, if the logistics could be worked through, makes complete sense. And if you're going to do blood in the field for EMS, then whole blood is just the ideal product. I mean, if there's no better suited time course for the patient to get whole blood than with EMS, because doing component therapy is a pain in the ass. It's, and just having a couple of units to temporize the patient, and then they get there and they might continue whole blood. They might switch to component therapy at that point. But for EMS, just loading in a small number of products that are going to have the maximum bang for the buck, then it's whole blood.
Yeah, I think that's obviously right. And there was a lot of debate over component therapy, and it almost felt like in the late 90s, early 2000s, we always had this kind of conversation like, well, IV fluid doesn't carry oxygen. And then we moved into these conversations about component therapy. And I was like, okay, well, plasma doesn't carry oxygen either. And it felt like this, we knew what worked, and we always found these other reasons to not use what worked.
Yeah, look, you could get by with RBCs, depending on the transport time, for a little while. But once that little while is up, then RBCs alone are...
Then what?
Then what? Exactly right.
Mm-hmm.
And so then you make the argument, and Antevy was making the argument, okay, well, we could have RBCs and we could have the freeze-dried plasma. Okay, well, yeah, I like that better than RBCs alone. That sounds great. You're lacking the platelet component. You're lacking all the other good stuff that lives there in whole blood. But, whatever you could get is what you should get. If you can get nothing, then you got to work with that. If you could get just RBCs, work with that. If you could get whole blood, great. If you're going to, now supplement that whole blood with something like freeze-dried plasma, perhaps fibrinogen concentrate somewhere down the line, we'll make whatever works. This is the same thing that happens in rural EDs. My blood bank, we have like nearly infinite supplies of product. And then I talk to people who are in critical access hospitals, and they have in the hospital 4 units of red, 0 platelets, and maybe 2 units of FFP that have to get thawed. And so, they work with what they can, and
right.
they keep that patient alive as best they can until they get them out. So whatever you could do, we'll work with it. But ideally, whole blood would be great.
I think that was kind of the argument with spray dry plasma, right? Where if we can't get blood into them, at least we stop blood from leaving them. And Dan, I want to get you in on this, because one of the biggest problems that we have in these organizations is logistics, right? It costs a lot of money to get blood out on the truck. Now, and we can talk about, our opinions on whether or not healthcare should be determined by cost. But, it seems that one of these things where it's a conversation where like, it's going to cost too much money to fix this person. I realize it's a very glib way to put it, but that is kind of the decisions that we're making, right? And so talk a little bit how that gets in the way and some of the roadblocks we run into.
Well, I think there's a lot of logistical roadblocks here. Blood is a finite substance. It's expensive. There is a shelf life to it. We have to be cognizant of that. Now, the studies seem to indicate that the waste of field pre-hospital blood is pretty good compared to in-hospital waste. It matches up fairly well. If you have your people on board, not a problem. My concern is every unit or is every county in the country going to have a blood program where we're going to be able to get this to the field. And I just don't think it's going to happen for everybody. That's why I'm excited about things like freeze-dried plasma, fibrinogen. One of the things about the upstairs care out there idea is if we don't bring a viable patient to the ED or to the trauma bay or the resus bay, nobody gets to work their magic. And this is just going to allow that to happen on a more frequent basis without all the downsides of just giving IV fluids, which we've had tons of journal clubs on it. We talked about this multiple times. All of our guests are kind of on board with it. So I like Scott's idea. I think whatever you can get into the field is probably what you can get. And it'll work great as long as we stick to doing it the right way.
I think that's probably right. One thing I want to ask you, Scott, because I think that listeners will hear and say, like, it's one thing if Scott Weingart makes a call and says, I would like blood in my hospital, please. It's another thing if, Jim Smith makes a phone call. So talk to me a little bit, I guess take a second, just explain, all right, you're a leader in your system. There's some resistance to getting whole blood out in the field. Once you hit that roadblock, I guess, give some advice on how to kind of push through without burning down the system.
Yeah, I mean, with the proviso that I'm not an EMS logistician. So what works for me
exactly.
in an emergency department may not necessarily be even appropriate to fight as hard as I do for some of the things I have fought for. So, with that in mind, I could give you a general idea of how you go about making systems change for something like this. And the first thing is you need the evidence on your side. And it can't be, picking and choosing evidence. If there's like 2 great trials that show the benefits of pre-hospital blood, and then there's one out there that's clearly against it, then your opponents who are trying to oppose this will clearly choose that one and say, this is most representative of practice. So you really need a balanced idea. Now, having, thought leaders that bridge the gap, like Entevi and others who, they're on the physician side and yet can support an EMS standpoint, that's going to be fantastic and potent. Then you have to come to the table with a open mindset of, if they're opposing this, it doesn't mean that they're evil. It doesn't mean that they're, have pitchforks. There's a reason from their perspective that makes complete sense to them. And the most useful thing is to say, hey, I hear you're kind of against this. That's the impression I'm getting. Let me see it through your eyes. Explain to me what you're seeing here. Now, sometimes they will say stuff that makes you understand they just don't want change. Whether they say it clearly or not, the essence of what you're getting is, this would be a pain in the ass. I'm not the one dying in the field. So, hey, I'm just not going to do the work to make this happen. All right. Well, now that's one set of countermeasures that you need to go. Now you need to kind of find someone potentially else that could bring some pressure on them. You want to, if you could find a patient that actually died and use that as a, it's horrible to like say it in that like that fashion, but we're not using them for evil at that point. We're using them so that could never happen again. If you could show some cases of like, look, this patient probably would have survived if we had pre-hospital blood. Okay, that could be potent. Now, on the other hand, if when you see it through their eyes, they're giving like legitimate logistical complaints. Like, for instance, when a lot of EMS services were trying to get blood, the barrier was, do we have a viable cooling system that's going to give the blood banks the numbers and assurances that product could be put back into the blood supply, right? Because it's not enough to have a fridge that gives the temperature. That's great. So now we could throw it away as soon as it expires. What we need to have a viable program in most places is, you keep it for a few days. You haven't used it yet. Give it back to us. We'll use it tomorrow. And here's a new one for you. So that means they need the precise and there is no, and you guys know this, but it's just for the listener. There is no more anal retentive, obsessive regulatory body than the blood bankers in every state I've looked at. So, they will, need incredibly detailed Picayune information in order to say those products are still good. So how do you do that in the field, right? There are ways now, but if you asked me 5 years ago, it would have been a much tougher sell to get them exactly what they needed in a way that doesn't cost the EMS service $100,000 per bus, right? Like, so that's like legit logistics. And if they're saying stuff like that, it's like, all right, well, now I know. So then you say back to them, well, if I fix those issues, then what would your feelings be? And if they're like, Well, if you got past that, then that would be okay. Okay, now you know what you got to do. So this is the mindset you have to get into. You can't get angry. You can't just say it's right. Patients are going to live. We can't let money be a barrier to patients living. So do this, because they're just going to say this person's naive. This person doesn't understand how things really work.
You don't understand the ways of the world, child.
The ways of the C-suite world. Exactly.
The ways of the system, yeah. Well, and there's certainly a difference between can't and won't, and it's something that I've argued both personally and professionally a lot. And it's a pain in the ass. I don't want to do it. That's a won't thing, right? And that's a different thing to get through with management. Can't is, Danny and I worked at a project years ago where they were like, our budget is finite. Like this is the amount of money we are able to spend. This is our capital. This is our limit. So if you want to have this in the field, wait, what do you want to lose? Right. So it turns into a sometimes frustrating but really interesting debate. Back to the life-saving stuff. Let's talk about dual sequential defibrillation and vector changes. Again, nothing new that's out in the data. This is one of those things where like 10 years ago, we were like, I don't know, it's real dangerous. The data is extant on this. But again, you've worked a lot in the receiving side of this. So talk to us about how you feel about vector changes, DSET, and what is this what this is going to look like for resuscitation moving forward?
Yeah, I don't know if the data's done. It's done for me.
No? Yeah.
I feel completely good about it. But we still have.
We should start adding that caveat.
Right,
the data is
like
for us.
There's my interpretation, and then there's where the gestalt of the organizations are, and they're still not ready. They won't pull the trigger.
Right.
The European guidelines, the most recent ILCOR guidelines, they're not saying do this. They're less hesitant than they were. But, despite a beautiful randomized controlled trial that, probably puts this evidence base higher than almost anything in cardiac arrest, maybe anything. Like, I don't know what's higher. It was a really well done RCT, and we have now, other observational trials that continue to support that RCT and not go against it. But for me, the data is pretty clear. And then, I spoke to Sheldon Chesky's, the lead author on these papers, and their follow-up analyses. And what I take from it is, first of all, we should be going posterior anterior as our first vector. Yeah. And that right there, according to him and according to my own independent interpretation of the data, eliminates any benefit from vector change. The benefit you saw from vector change was starting in anterior lateral. If that doesn't work, go then to the superior position. But what people, I think, erroneously extrapolate is, oh, well, if I started in anterior posterior, then I should change the pads to anterior lateral. And there's nothing to support that. There's no data that says if you were already in the superior pad position that you should go to the inferior one and hope it works.
So it's kind of like the best time to start was yesterday. The second best time is now.
Yes, I love that. Yes, that's exactly right. So now there's a little bit more logistics to get an anterior posterior pad position, but there's no one better at the logistics of CPR than EMS. Like, you guys and gals are, 10x better than we are in the emergency department at this. You've embraced pit crew methodology. You understand that, a compressor could compress for like 120 seconds and then should be switched out, versus us. You'll see the same RT for 18 minutes. And it's just like the compressions have gone to crap. So I don't have to tell EMS how to get logistics of CPR done, but it's a little harder to get them in a posterior anterior pad position because you got to break, whatever you're doing and sit them up. Now, if you're using mechanical, it's pretty easy to get the posterior pad on and the back plate on, and then sit them back down, do some hand CPR as you now put on the anterior pad and put the mechanical CPR device through the arms of the compressor. And then, so the hands-off time doesn't have to be a lot. But it's probably more than anterior lateral. Like, what are you guys starting with at your service?
The standard is kind of moving toward AP CPR device and then anterior lateral. And again, it's part of the problem, I think. And Dan, I want to hear your opinion on this as well. Is a lot of it is, I don't know that it's resistance to the data. I think a lot of it is we're not accustomed to, like, it's the simple thing, right? We're not accustomed to rolling CPR patients, right? So I think a lot of what happens is we get on scene and, the AED is already on, compressions are being done, and we all kind of fall into that automatic mode where, this is already happening, so let's just go ahead and do it. So I don't know, Dan, what do you think?
Yeah, I think that kind of inertia that we get on scene, because, we run a tiered system. So the medic is not with the EMT on our calls. EMTs, cops get there, they start the process. We roll in and we start taking over the advanced level of care. And by that point, most of this stuff's already done. I agree with you, Ed. I think most people realize it's better to do AP. I think it's easier to go anterolateral.
Right.
And I think that's just what we've got ingrained into our brains. And especially like in stressful situations, you're going to revert back to what your small brain's going to take over. That being said, I think it's important for people to start doing it. We need to start thinking about this, especially when you're thinking about double sequential. And we've read that study. We know you can do this stuff. You don't need 2 monitors. You can have a monitor and an AED. This is not hard to do. And if the AED is already applied, I'm going to tell you 9 times out of 10, that's going to be anterolateral. It's really easy for us to do AP. And then we can just move ahead. And that's, I think, where we need to start going. I'm going to talk it up. We have our preceptor competencies coming up, and we're going to be teaching people. I'm definitely going to talk it up this fall. I think we've got enough evidence behind it to show that we can do better with this. And I think it's just time. And I think it's just going to take time.
I don't like
There's
the
also-
roll. Yeah. So, and that might be why people hate it, because the log roll sucks. So I like sitting the patient up, and you could do it with one person. You just grab them behind the neck and you just lift them up so that they're sitting up, and then you can slap the pad on with your other hand. It's a lot easier if there's 2 people, and there's always 2 people at a code if you're, the medics are responding at that point. So one person should be grabbing the patient's right shoulder and supporting their neck and grabbing the right shoulder. You, as the pad person, grab their left shoulder with your left hand and you slap the pad on with your right. And it's just a second. Like, there's nothing, as long as they're not a traumatic arrest. And then, really, why should we be doing this anyway? They're not going to need a defibrillation. It doesn't matter. Put it on anterior lateral. But if you are just, slide them up, slap it on, lie them back down, it's gorgeous. It just takes a moment.
I think one of the biggest hesitations we run into is also like the impression of it, right? I know anecdotally, I feel like I know that a lot of people aren't familiar even with AP pad placement. Certainly a lot of BLS providers are not familiar with it. And, we could spend hours talking about how to disseminate information out to BLS providers. So I think, again, it's one of those, we revert back to the easier, the path of least resistance. And, then there's the other data where, it's an asystolic arrest. So I'm putting pads on because, it's all of those kind of factors. Better or for worse.
What Dan said, I think that's the win. Like, if you come there and they've already put on an anterolateral with the AED, that's in some ways beneficial, because it means you can actually get a shock in if they deserve one prior to the time of, hands off while you're putting a posterior pad on. And now you're just set for the dual sequential, right? So, in some ways it doesn't even matter if you could convince BLS or the first responders to do it right. It just means telling the medics, like, I know it's like a little bit of a pain in the ass, but put new pads on.
Right. I need you to be inconvenienced for 5 seconds.
Exactly right.
Yeah. All right. So let's get into some of this pressor stuff, and then I want to get into wellness before we get out of here. We had Eddie Gutierrez on a couple months ago talking about the better pressors for EMS. His general opinion was kind of give a pressor that works. He tended to revert back to norepinephrine. I want to get your input on that, your thoughts on this. In your mind, is there a better pressor for EMS, or is it just kind of like, do what works, get them to the hospital?
I don't even know how to answer this. Like, what pressors are there? Like, I hope no EMS service is still using dopamine. Like, is that gone finally?
We still have it on the truck.
Not only is it on our truck,
we don't use it.
Scott, it is required to be carried in some states.
Okay, so this is a worthwhile conversation.
This is where it's fun. Is that I feel like Danny and I are very lucky to have talked to a lot of thought leaders in the industry over the years. The fun part of the conversation is we'll talk to them, like, hey, what do you think of this? I'm like, why would that even be a question? Like, fair point. Yet here we are.
All right, so there you go. So now this is worthwhile. So stop using dopamine. I mean, I'm sure other people have spoken about this already, but it's worth saying. It's just a dirty drug. It causes atrial fibrillation. It has endocrine effects. It has negative kidney effects. It doesn't do the job because it's not a direct pressor. And there's just no reason to stock it, to use it, to have it. There used to be a reason in that people thought erroneously that it was safer peripherally than norepi. That's been debunked. They're both just equally okay, but not great. What's that?
What do we think the origin of that? Because I do remember, and
so
I know Danny
here's the deal, and it's such a great question. Like, because you should always know the origins of stuff, because then it starts making sense how a group of people could have thought this for 30 years. So it used to be you'd always start with dopamine. And I was at the very end of that era where you'd go to dopamine and then you max out at 20 micrograms of dopamine. And then you'd add in norepi. And then you'd keep going up on the norepi since the dopamine was maxed. And these patients would be near death and they'd be on incredible doses of norepi and they'd start, having no perfusion in their arms and legs. Because remember, this was a time before echocardiography existed.
Yeah.
So you had no idea what the heart was doing. So you just keep going up on the vasopressors, even though their reason for needing so much vasopressor is they were a complete cardiac shutdown. They had cardiogenic shock, whether sepsis induced or direct. And so now you're trying to fix a heart problem with a vasopressor because you have no idea what's going on with the heart. And yeah, of course, patients died from it. Levofed leaves them dead. That was
leave them dead. Yep.
Yeah.
Oh yeah.
And patients would start losing fingers because that's the way you lose fingers is you take a patient with no cardiac output and you keep raising their vasopressors. And everyone's just like norepinephrine equals, loss of fingers, loss of digits, malperfusion, etc.
It's a literal life over limb consideration.
But they didn't live. Like once you got to that point and missed the boat, they just all died. Hence the leaving them dead. So, norepi got this horrible reputation based on the timing of when it came in, which was in the peri-death period, and it was being used inappropriately. When it was actually looked at head to head, well, of course, none of that happened at any greater rate than any other vasopressor. And then the norepi extravasation issues were also from a very different time where things weren't being monitored. They weren't being looked at. These were still the days where a patient with sepsis would be, just left in a corner for 14 hours. Yeah, if you do that with any vasopressor, dopamine or norepi, not good things could happen when given peripherally. But for an EMS transport time, norepi is at least as safe as dopamine, is what we could say peripherally.
I think that's fair. And there's a lot of different administration routes we have. Go ahead, Dave.
And just as an aside, Ed, you and I are kind of lucky. Yes, we have dopamine on the truck, but nobody tells us to use it. Most of our time, we start norepi on our septic shock patients and our cardiogenic shock patients. Scott, what about the agencies that don't have norepinephrine? Is epinephrine or an epi drip an acceptable alternative? And is it better than the dopamine? And is this something you can engage your medical director with?
Yeah, I think I would choose an epinephrine drip over dopamine, but that shouldn't be a choice because, what you want is you want consolidation and you want simplicity, right? In any resuscitative specialty, and especially EMS, where you also have limited space added to the entire mix of what we have in emergency medicine. There's no reason to stock it, right? So that right there, that would be a marker to me of a uninformed medical direction or county or state organization. If they're still, it's fine that you guys have it. I'm not maligning New Jersey. I'm saying they've given you norepi as well. That's a sign of a smart system, right? If they've only given you dopamine and then you have code dose epinephrine in the boxes, that's a failed system. Like we have bigger issues than what Pressor to choose, because that means whoever's doing the medical direction hasn't updated for like 20 years. And you get 10. 10 years is the standard adoption cycle in medicine, which already is baffling. Like
way too long.
Way too long. But fine, if they're only 10 years out of date, they're right on, they're right on the curve. But if you're 20, 30 years out of date, we got problems here. No service should only have dopamine. A big issue. Okay, if they did, yes, I would prefer epi, but I should never be put in that situation as a medic. I should at least have a choice. And if I don't have a choice, then the sole one should be norepinephrine in 2025.
And before we move on, I really want to get this out because honestly, you were the father of push dose pressors. I listened to the EmCrit thing on that. I was going to people and saying we should be doing this. Our medical director at the time was a big early adopter of things and we got to use it. However, it became a crutch with us because we had people who would give 2 or 3 syringes full of push dose and not want to put them on the drip. Talk to us about that. Like my feeling is if you got to give more than a couple juices of 10 to 20 mics of epi, during your push dose, you need to be thinking about that drip. It needs to come on. It's not something that will make your life easier. It's better for the patient.
Yeah, I'd go a step further, Dan. I love what you're saying there. And I'd say there should never be repeated push dose pressor administration in a paramedic type situation. The reason we sometimes do repeated push doses is you're in an ICU and the medication has to come from the pharmacy. That's the situation you're in the ICU. Listen, like anesthesia, like me in an emergency department, I'm just making my own meds. Like I don't have to wait. So there's no excuse. There's no excuse to give multiple doses. If you give one push dose, they should be on a drip because I promise you, even if their pressure looks okay for a little while, at some point it's going to plummet. And then you're going to have to give another push dose because you didn't put them on the drip. Just put them on the drip, leave it super low, or have the drip ready to go, standing by, and you could not have it turned on. But if they needed a push dose, they're going to need the drip at some point. If not in the transfer, then at the worst possible time, that right as they land in the ED, all of a sudden now they're back to 50 over 30. And we look at you and you're like, what the hell? And you're like, no, they were fine with the push dose. It's like, well, yeah, why didn't you care enough about us to not have to make us, run to fix this right now? So yeah, just always make the drip and they're always going to need it. Now, what it should be is interesting because, I'm the father of the words push dose. But there was bolus dose pressors way before my time from the anesthesiologist, and they were all using phenylephrine. And they were using phenylephrine because they could get it pre-mixed. Phenylephrine's not a great drug in the resuscitative specialties because you don't want just the vasopressor response. You also want to give the inotropy. And phenylephrine alone is actually making the heart not work as effectively. So you're actually losing inotropy when you give phenylephrine. So phenylephrine's not a great drug for EMS or emergency medicine. Epi's wonderful, but you got to mix it yourself. You just can't get it pre-made in the United States. There are some compounding pharmacies that'll do it for you, but compounding pharmacies are hit or miss sometimes. And there was like this big controversy. They were sending drugs that weren't appropriate. And some of these compounding pharmacies that were making the push dose epi had to close down. So I don't like it. What I would love to see in EMS, if you want the simplest, least medication issues possible, is do you guys have pre-mixed norepi yet, or you have to mix it?
We have to mix it.
Yeah. And that's like most EMS services. And so the ideal, I think, for a medication like this would be to get pre-mixed norepi, right? And then you figure out what your mix is. And most of them you could just use as a push dose. So most of them like 4 and 250, which is the standard non-concentrated mix.
That's
half
what we
cc
use.
of that is 8 micrograms. That's perfect, right? So you give half a cc, you can give 1 cc of that, meaning you're just pulling it from the bag and pushing it, and then you could start the drip with that same premix. Now, if you're not in a place that has that, if your mix is 4 and 250, what I would love to see people do as their push dose is mix up their norepi bag, ready to go as the drip, and then draw back from it as a push dose. And now you don't have to worry about mixing instructions. You just have to learn once what our norepi mix is, and then what the push dose equivalent is, and make, learning aids for that so that, they're there. Because every time you give a push dose, you should be looking at something. Even now, I tell the nurses who have done it for 5 years, I've taught them 5 years ago, they've done it probably 1,000 times. I still tell them I want every time you to look at the label, because we made our labels for our push dose meds having the mixing instructions on the label. So on the label itself, it says epinephrine, with the tall man lettering, it says, 10 micrograms per ml. And then underneath it, it says, take 1 cc of cardiac arrest dose epinephrine and put it in 9 cc's of normal saline. And so the mixing instructions are there. I tell them to look every time. So you always want some form of aid memoir for this push dose, because it's been proven in numerous pharmacy papers to be a source of medication error if you're not doing it carefully. So make something that's like an aid to that. Labeling the med with something with the mixing instructions is a great way to go. And then if you could draw it up from your norepi drip bag, my God, you've just eliminated an extra medication.
Got everything right there.
Everything's there. And norepi is a fantastic push dose. It has some inotropy. It doesn't cause excessive tachycardia. It gets you what you want. The pressure comes up. And I think it's the cleanest way to go for EMS.
No, I think that's probably right. So one of the things that you've worked a lot with, especially with EmCrit and with medicine and like that, is you've talked a lot about mental health. One of the things I really like about the newsletter that EmCrit puts out is you will talk about whatever book you're reading that week. A lot of times it's something that's not medicine or forgive the term, hard thinking type of content, which is very exciting for me because it's important to get out of medicine We may all love the industry, but it's often one of the most stressful industries we have. So talk to me a little bit about the burnout that we kind of see, actual items, whether it's social media detox, sleep hygiene. We talked on the show a lot about burnout and how it affects EMS workers. Certainly you're in a very high stress, high impact kind of place. So I know that you had a similar experience. So give us some of your insight on that.
Yeah. I mean, this is a topic near and dear to my heart. I've been doing physician coaching for, I think it's like 6 years now. And this is what a lot of my clients come to me with is burnout. And there's multiple directions that we hit when I'm interviewing a new client. And in these resuscitative specialties, a few things happen. And you've alluded to some of them, Ed. First off, we have such a high stress job that our detox time is we just let ourselves off the hook from, being clever about it. And so, we hard drink, we hard party, we eat badly, and we sleep like crap, and then we come back for the next shift. And you could find this in any of the high stress gigs, chefs, all of them, it's seems almost monastic what the advice we give, but you have to start treating yourself as a high performance athlete, not a pound and chill type profession, because you're not going to be in it for the long haul. So we teach folks how to have sleep hygiene. We teach about proper nutrition. We teach about recovery time and having a long career and not a short, brief burst of flame. So, that's one facet of it. The other facet, though, the real burnout that I see with EMS is we lose sight of the beauty of the profession. And the beauty of the profession intrinsically is that we're helping fellow human beings. Some people lose sight of that. Some people never had that in their sights in the first place. And they're there because they like taking care of sick problems, right? Now the patient is kind of superfluous to that. They want to take care of really critical things. And then, first of all, when they don't get those for a while, you get the patient calling with back pain, or the old lady is fallen and can't get up. You get a few of those, and you're like, oh, what the hell? This is the worst shift ever. And then even if you have the high drive-in calls, you start not seeing humanity anymore. And, you start, how it starts with the cynicism and, look at that scale over there. And, you start talking about them as subhuman. And it's in some ways a defense mechanism that's completely understandable, because we take a lot of abuse in the resuscitative specialties, and this is our shield, right? It's like us against them. It's like my partner, I got their back, but these assholes over here, and once you start losing that, it's really a slippery slope to bad stuff. So we try to get people to reconnect with what is intrinsically beautiful about the job, which is you are being paid, albeit not nearly enough, but you're being paid to go and actually help your fellow human beings. And once you start reopening your eyes to that, you start interacting with people in a slightly different way. And then your interactions with them get better because they are giving back what you're giving to them. And it becomes a reciprocal exchange of, compassion and all of these touchy-feely things that you might not think matter. But your heart does know. It's keeping track of every time you are like, oh, that fucking dirtbag, I can't believe what they were doing. Of course, if you drink 17 beers and get in your car, you're going to smash it up.
We'll say that while smoking cigarettes and drinking energy drinks as well.
100%. And look, I've been there. It's not like I'm this virtuous guy with a halo on my head. I've learned from comparing the two. The cynicism versus this. You have a limited longevity with that, because each shift, no matter how much cool stuff you see, is taking a bit of your soul. And if you start interacting the opposite way of like, you see the totally drugged out guy that you've picked up, 15 times in the past month, the second you stop thinking of, oh my God, I can't believe this dirtbag's calling me again, to, wow, am I lucky that I didn't get the life circumstances that led to this poor guy, right? Which is absolutely true. Like, every single person you see, if you were given their same gig, if you were given their same life experiences, you would be doing exactly what they're doing with zero variance, because that's the way it works. They are just a circumstance of what's happened up until that moment. So, if you look at that and now have gratitude because you live a pretty good life and you have compassion of like, wow, this guy really probably is not having a very good life if he has to call me to pick him up and take him to the emergency department again the 15th time this month. You're going to have a different vision of your job. You're going to have a different vision of your patients, and you're not going to be burnt out.
And I think that it's
That's
also
amazing.
important to kind of, it's great. And I think that as an industry, we're not very good at, treating mental health, especially with our EMS staff. There's a lot of, the next call is pending. You've got to turn around. You've got to go. It's very easy, I think, to see the worst parts of humanity as part of your job, and then just assume that that's, the worst part is the standard. And yeah, it's, and again, this is something we've talked about on the show, and obviously personally a lot. It's one of those things where like there's no good answer because everything affects everybody differently. So it's just an ongoing conversation that we like to have. But one last thing that I want to ask you about before we get out of here, it's a technology question, and I know that this is one of your big things. Talk to us about ultrasound, its applicability for EMS. Give us one big, fun, sexy technology thing, and then we'll get out of here.
Yeah, look, I think it should be on the buses. I think it's utile. Like, if nothing else, just for starting IVs, it would be worth it to get. Now, it's an investment.
Hang on, Scott. We're paramedics. We can start IVs hanging upside down.
I have no doubt.
Right?
I have no doubt. But there are patients who it just makes your life easier, and it all of a sudden it's not misery, but I'm going to get it because I am not going to lose my rep of never not being able to get an IV. But there's a lot of utility. I think it's overused in many emergency departments, and that's fine. But
do you feel it's overused because it's like people rely on it too much as a tool, or like if your only tool is a hammer, everything's a nail kind of thing?
No, it's more like, ooh, shiny toy. Let me do this. Yeah. And for some of them, it's a training thing, and that's fine. Like, the residents will probably be doing it too much, but they're doing it because they need to learn. Okay, that's fine. There are some attendings who are, every patient is getting a 20-minute ultrasound examination. And I'm like, well, what question are you answering that we need to answer right now? That's really what it comes down to. Like, you have to have the indication first. Like, there's a crucial piece of information I need to know. Okay, can I figure it out in another way? No, I can't. Okay, let's do ultrasound, because this is the term that we've come to, but it's not the greatest. But a lot of times ultrasound is just masturbation by sound, right? Like that's sure. In essence what it is. And it's like, okay, well, you're just satisfying yourself, but you're not satisfying your partner, the patient, right? Like you didn't need to know it. Like in the emergency department, I could give you an example. It's like, you delay going to the CT scanner for a bad trauma patient to do a fast exam, which is the ultrasound for trauma. When I'm like, okay, if it's positive, what are you doing? We're going to CT. If it's negative, what are we doing? We're going to CT. Okay, well, that was 5 minutes of a really critical portion of that patient's life that shouldn't have been wasted. And that's, the fear. EMS, look, if you're already on the road, do whatever the hell you want if it's not in the way of another modality or treatment. So, if you came in and said, hey, this patient's fast positive, I'd love that piece of information, right? Like, and that's something EMS could tell me. But if it's at the expense of getting the blood products in with the alacrity they need, or, monitoring their, the fact that they're peri-arrest, okay, well, then that's a problem. So I have no problem with ultrasound and EMS. And if you sat me down and said, Scott, write down 5 best indications for EMS, I'm sure I could come up with some good ones. But in many services, I would put getting, blood in the field, if in terms of that capital investment, ahead of it.
Okay. And I think that's a really great point too. And it was a nice way to wrap it up, where, there are people who are going to have to make financial decisions for their departments. Again, it's super easy to sit and be cynical and be like, well, we have this much money, we should just, get the thing that I want. So I guess the just a quick, if you had to choose, I guess you could go to whole blood over ultrasound. And I don't know what the capital investment between those two things would be, but I like the idea of, we know how to start IVs, we know how to put blood in, we can figure out the ultrasound stuff later. Scott, this has been terrific. Yeah, exactly. Thank you so much for your time. Everyone that's listening, if you don't listen to EmCrit, get on it. Scott Weingart from the EmCrit podcast. Thanks so much for your time, Scott. For the Overrun, Ed Bouter and Dan Schwester, subscribe to all of our stuff. We'll talk to you all next time.
Bye.